Thank you very much to Corey for inviting me back again this year, and for giving me this topic that sometimes can be difficult. Brace yourselves, I have no Kaplan-Meier curves. So, no relevant disclosures for this topic. So we're going to talk about, so my program is going to differ a little bit then from Pallavi's because I'm going to talk about more about the conversation and how we talk to patients and family members. There's a couple models that are out there that have been published on about how to use good communication strategies in this situation, family conferences, and then difficult discussions. And there is a lot of data out there about having these discussions and what they show, so we'll focus on that. I really think there's two main strategies here. We can talk about the studies and what they suggest and understand communications, but the second part of this is that it's an art. Medicine is still an art, and having these conversations is still an art. It's about knowing your patients, understanding them, and looking for signals in the right timing to have these conversations. So, prognostic acceptance. So this is really complex in patients. It depends on their personality, what their views are on life. Non-acceptance is associated with suffering, depression, and hopelessness, and difficulties with social relationships. So really, this is a difficult thing for patients to come to the acceptance of their prognosis, and it's an ongoing process for them during the journey of their illness. In a study looking at 686 patients with metastatic lung or colorectal cancer, they were surveyed 3 to 6 months after diagnosis, so good time after diagnosis. Only 16% of patients claimed to know their accurate prognosis, and this is how it was defined in the study. Now, I looked at this and I thought, okay, so either us as healthcare providers aren't getting the message across, but also when you specify lung less than 2 years, this is maybe not all our fault then, I thought about this, because maybe the patients didn't want to ask exact years. So I think, it's incumbent upon us to say to a patient, yes, this is not a curable disease, but at the same time, it may have not come up, and it's exactly 2 years or less, or 1.5 years or less, depending on your strategy, so you better start thinking about that. Maybe patients didn't exactly ask the number of years. So I think this goes both ways about what we're saying to patients, but also what patients want to know and what they're going to ask you. The other thing that is a common thing that you'll see throughout all these studies, the earlier prognosis was discussed, the more understanding that was reported. And that's something that goes on through each of these studies. Okay, so let's talk about communicating with the patient. So how about the patient who doesn't want to know? We've all had this patient in our clinic who comes in and says, I don't want to know anything. I don't want to know anything. Just tell me what I'm going to do. Tell me what my treatments are. So I think there is a little bit of this where you can sort of ask about, what is surrounding your feelings about this? Because this can help them make treatment decisions in the future. So it's not something that you can necessarily completely blow off, though gently talk to them about it. Obviously reaffirm their concerns, that opens up conversation, and always tell them, okay, we don't have to discuss any of that today, but in the future, whenever you feel like you need to ask me, that's appropriate. Okay, one of the models that's out there is called the communication model. I'm not going to go through each one individually, but you'll see throughout my slides that this is complex. There are multiple dimensions to this. There's not one exact right way to do it, and there's not just one aspect of it. So family is a part of this. Having a relationship with the patient, having a team structure, so using other parts of your team, like your palliative care service or your psychology service, social work, using other parts of the team also. Active listening, that's also going to keep coming in. I know it's hard in a clinic where you're busy and you're seeing a lot of patients, but being quiet sometimes is the best way to facilitate communication. This is another model that I added this year. This may be the only slide that you see today that was not primarily authored by a physician or a healthcare provider. This woman who authored this has a master's in divinity, so a little bit of a different take on how to have challenging conversations or end-of-life conversations. So affirming the patient's belief, I'm hopeful. But she does go down and say, so a lot of this initially is talking about, okay, I join you in hoping, and I hope for you, and I hope this and that. But then say, I do want to talk to you about some medical issues, though, that I think it's important that you would know. And no matter what, always assuring them that you will be with them every step of the way, no matter what they decide. So a lot of reaffirming here. There was a doctor who was also on the paper, but was not the primary author. Family conferences. So this brings up another aspect of communication strategies. So this was a study looking at 140 family conferences. Patient participation showed an increase in discussion of goals of care, but I like the last bullet point here. There was a significant decrease in conversation about prognosis and symptoms of dying while the patient was present. And I think this brings up our family conferences that we might have inpatient, where the family or you even may not want to discuss the symptoms of dying in front of the patient, but that when you have that conference, in the family waiting room or something like that, this may be a more appropriate time where the family would feel comfortable talking about it with you rather in front of their loved ones. Okay, so which factors are important? So this is another study, so 352 patients. This is just lung cancer, so I tried to tease out the studies that had metastatic lung cancer patients in them. So 54% of these patients received disease-directed stage-appropriate treatment. That means almost half of them did not. And what was the reasons that these happened, or what was the higher probability for appropriate treatment? That was when the risks were well-defined, the goals of treatment were talked about, the chance for cure was talked about, and I love this fourth bullet point. Patients reported this. They said if the doctor or the nurse was warm and friendly, they were more likely to get the stage-appropriate treatment, which Tracy's in the audience, and I think about this because her and I work together, and we're probably two of the most type A, high-strung women in the room. So you put us in our clinic, and we're like the Tasmanian devil running up and down the hallways. But when it's time to have these conversations, I think when you go into the room, it's a deep breath. I'm going to listen, I'm going to slow down, and I'm going to talk about these things that are important to the patient and their families. Okay, more on end-of-life discussion in particular. So patients who have already discussed their wishes for end-of-life care feel less stress at the end of their life, and so do their families. So it's important to have these discussions in the proper way. I put NCCN and ASCO up here. So this is the NCCN guidelines. They state that end-of-life discussions should begin earlier in patients with incurable cancer, during periods of medical stability, and with the physician who knows the patient well. So, for example, this should not be on Saturday at 1 in the morning with the resident in the ICU. That's not the person who knows the patient well. It's not a time of medical stability. Unfortunately, I think this probably happens a fair amount. On average, end-of-life discussions, and this is Jennifer Mack does a lot of wonderful research in this area. In one of her studies, she reports that on average it was 33 days to have that conversation before death. So it should certainly be done earlier than that. Now, this is the ASCO position statement. This was published in JCO in 2011. I'm obviously not going to read that to you. A lot of the same elements here are key for patients with advanced cancer and individualizing their discussions. This statement focuses more, I think, on continuing to make sure that the patient has been offered all treatment, offered clinical trials, but at the same time using palliative care and making sure quality of life is important to them as well. Okay, more studies on end-of-life care. So this was a study looking at patients. So I actually have two studies on here. So only half of competent lung cancer patients were involved in end-of-life decisions, despite having discussions about it. So that means that either they were losing their ability to make the decision, or when it came time to make the decision, they weren't able to do it. Another study looking at inpatients showed that 79% of them had the capacity to make the decision when they entered the hospital, but then 40% of those patients lost the ability to make the decision when the time came that they needed to make the decision. So therefore, you're going to shift that decision-making upon the surrogate, with the last bullet point saying that when the surrogate ends up making the decision, they were more likely to have aggressive care at the end of life, whether or not that's what they wanted or not. So again, it's important to have these conversations when the patient has the ability to make the decision. It's a large study looking at lung and colorectal cancer patients. 50% of patients in this study had at least one aggressive measure at the end of life. 16% received chemo within 14 days of the end of life. 9% were in the ICU. 40% hospitalized in the last 30 days. If you had the end-of-life discussion prior to the last 30 days of life, it was less likely that they would have an aggressive measure at the end of life. So again, supporting the earlier time frame. Informing a patient when death is imminent does not increase pain, anxiety, confusion, nausea, or respiratory problems. It was also associated with a good death, I put that in quotes, because what that meant was that the patient died in their preferred place, wherever that would be, whether it was in the hospital or at home, and the family was informed and received bereavement. So again, we don't want to do it at the very, very end, but if you do discuss it with them, it's not going to increase their symptom burden. Another study of advanced cancer patients, this didn't specify just lung cancer, so it was advanced patients. Only 37% had actually had the discussion. Again, it was not associated with depression or worry, which I think sometimes we would think it would be. Of the patients with the end-of-life discussion, there was a decrease in aggressive care, so this theme continues throughout each slide. And again, it didn't increase the depressive disorders in the caregivers as well. That's what's interesting about this study. It looked at the caregivers as well as the patient. So it did not put anyone in a terrible downward spiral to have these discussions. I also wanted to look at specific populations because remember I said this isn't art, so not everyone is exactly the same on what their beliefs are or how they will, receive or perceive this conversation that you're having with them. So I looked at culture and racial differences in particular. So there's 4 different studies here that I sort of put together in 3 bullet points. So Black patients are more likely than white patients to receive life-prolonging care at the end of life, and that was specifically CPR. Though if they were still on chemotherapy at the time, it was equal. So if they're still receiving aggressive care, no matter what your cultural or racial difference is, if you were still receiving chemotherapy, it looked like you still wanted aggressive care, no matter what. White patients were more likely to receive end-of-life care that they preferred, whether it was aggressive or not. So it seems that someone was at least looking at their advance directive or looking at what their wishes were. And patients who report high religious coping are more likely to want aggressive care at the end of life and life-prolonging care, which is interesting because when I saw this study, I would have thought the opposite, but this has actually been replicated in studies as well. This is a study that was done by an OB, actually, an African-American woman who actually has an interest, besides being an OB, in end-of-life care and discussions and looking at patients' views about it. And I thought this was interesting because it looked at the provider view, so this is us, versus a patient view. And she looked at the African-American views of a good death versus a provider view. And I found this to be interesting. A lot of stuff on the left-hand side would be things that I would think, pain and suffering are unnatural and they shouldn't be necessary. People want to know when death is coming and they want to expect it. But if you look on the other side, that's not what all patients want. Some people think, suffering, this is a normal part of my life and my death process and this is how it should be. Some people think, God is in control, so you can't tell me when. Don't tell me when you think I'm going to die. God is the one that's in control and will decide that. So it was a very provocative and interesting paper to look at. I have 2 sides, one teaching caregivers and talking to children. I'm not going to go through again all the bullet points, but I wanted to include it in a slide for your reference. Again, a lot of this, because patients will ask you, family members will say, how do I deal with this when my loved one is going to be dying? And a lot of this is talking about letting the person talk to you and express their fears and concerns and be a listener and be supportive of them, respect their need for privacy. The biggest take home about talking to children about end of life is to be honest with them, gently honest, but honest, because you don't want to tell them something that's maybe inflating what the truth is, and then when bad things happen, they're devastated and they're not trustful of you. The other thing that's important is to make sure that they know that when their loved one is gone, that they will be taken care of. That's apparently what most children are very concerned about, that there won't be anyone to take care of them. I have a couple interesting slides here about prompt lists. Are they helpful? This is for patients. So a checklist for a patient to bring into you, and you can refer patients to this. Patients will ask me, well, what am I supposed to ask? What should I ask you about this process? And that's going to be different for everyone. But there are studies that look at checklists for patients to use to ask their physician or their caregiver or their provider about the death process or end of life. And you can see that they do improve higher level of performance, ensuring adherence to the key processes, things that the patients really do want to know. Again, it promotes patient and caregiver discussion with the doctor, so it might help you have that discussion. So you may want to refer your patients to a checklist about what to ask. Other things that are on checklists that patients may ask, so this is a sample version of one. Do you have a palliative care team? What physical symptoms may I have? This is what patients may come in and ask you. So you should obviously be prepared to answer them. One slide on documentation. I felt that this was necessary in this world of electronic medical records. Where is it in that computer screen that tells you when your patient is spiraling downhill in your office and you're calling the ambulance? Where is it? Is it clearly documented what their wishes are? You may have documented it and then not remembered where it is. So this was a study looking at where it was documented, and it was all over the place. So there was no good standardized place. So I really recommend in your electronic medical record, have a place, I think ours is even highlighted in yellow. And we have a free text area in ours too that you can say, on this date, I had this conversation with the patient. Even if they already have an advance directive, to at least say, I also had this conversation with the patient that says this is what, to clarify further what they would want. Also, if there's reminders in the electronic record, that's helpful as well. So if you see a patient, a little pop-up message that says, hey, this person doesn't have an advance directive, maybe you want to talk about it. And that improved the documentation of having the advance directive. And then lastly, training programs. Well, why would we need that? Well, so there's actually studies to show that training programs for healthcare providers, doctors, nurses, whomever it would be, where you can go and learn how to have these conversations. And one of the key elements of these programs is actually modeling it. So you go up and you have an actor who's a patient there, and you have the conversation, and you have it in front of your peers as well, so people can critique you on how well you've done. And it's really weird. It does really put you in an interesting situation to let yourself have the conversation and then see yourself and have people critique you on how you do. So there has been improvement if you're willing to participate in these workshops. So in conclusion, having decisions about prognosis and end of life should occur earlier and at a stable time. And the one thing I'll pause here, I have 1 minute left so I get to say something, is that you're not a bad oncologist or a bad nurse for not saying on that very first visit with stage 4 lung cancer, oh, and here's how long you have to live, and do you have an advance directive? That's probably not the best time to do it. The first time you see them with stage 4 lung cancer, there's a lot of information going out there. And you clearly don't have that close personal relationship with them at that time yet, because you don't really know them that well yet. So it's not wrong to let the relationship evolve over time and then start working those discussions in, as long as it's not within 30 days of their death. Facilitating discussions about prognosis or end of life using certain phrases or validating concerns is a good way to facilitate the conversation. Does not increase their symptoms of depression, pain, dyspnea. Does not increase their symptoms to have these conversations. And again, just knowing your patient and feeling comfortable with having the conversation is really important.